Now, now I would like to talk about the B cell and the T cell disorder. In B cell disorder, always remember A, B, C. Selective IgA deficiency, Bruton sac amyoglobulinemia, and CVID, common variable immunodeficiency disease. In selective IgA deficiency, it may be familial or sporadic. Most common primary immunodeficiency and may arise secondary to certain viral infections or medications. Majority asymptomatic can see airway and GI infection, autoimmune disease, atopy, anaphylaxis to IgA in blood products, anaphylaxis to IgA in blood products. So in selective IgA deficiency, there is atopy, asymptomatic, can airway infections, and autoimmune disease, and anaphylaxis to IgA blood products. There is decreased IgA with normal IgG and IgM level, increased susceptibility to giardiasis, and can cause false negative celiac disease test and false positive pregnancy test. Very, very, very high in selective IgA deficiency. There may be false positive serum pregnancy test and false negative celiac disease test. Now, the Bruton sagamma and CVID. In Bruton sagamma B game, if you think about the B game, what does the B game means? That means B cell count, IgG, IgA, IgM, IgE. So everything is low in Bruton sagamma but B game, B cell count is normal in CVID. First difference. B cell deficiency, BTK gene problem, no B cell maturation, it is X-linked recessive, occurs in the boys, recurrent bacterial and interviral infection, decreased maternal IgE, and absent B cell in the peripheral blood cell, decrease immunoglobulin of the all classes, absent or scanty lymph node, tonsils, primary follicles, germinal cell. Live vaccine is very, very contraindicated in here. Live vaccine is contraindicated in Bruton's gamma globulinemia. In Bruton's gamma globulinemia, live vaccine is contraindicated. Live vaccines are contraindicated. And in CVID, there is defect in B cell differentiation, cause unknown in most cases, may present in childhood but usually diagnosed after puberty. So Brutons happen in the boys, Brutons happen in the babies, and CVID happens present in the childhood. CVID may present in the childhood but usually uh, present after puberty, increased risk of autoimmune bronchitis, lymphomas, cynomolmar infection, decreased plasma cell and decreased immunoglobulin, decreased plasma cell and decreased immunoglobulin. Okay, now the T cell disorder. Now the T cell disorder. In T cell disorder, it is, if you remember the Citadel, which is an episode like CITA. What does it means? Chronic granulomatous disease, chronic granul chronic granulomatous disease, and I for interleukin 12 receptor deficiency, interleukin 12 receptor deficiency, thymic aplasia, thymic aplasia, and chronic and autosomal dominant hyper IgE syndrome, autosomal dominant hyper IgE or job syndrome. In chronic mucocutaneous disorder, in chronic mucocutaneous, C for chronic, C for candida, C for chronic, C for candida. So T cell dysfunction, impaired cell mediated immunity, candida classic form caused by defect in the AIRE. There is persistent non-invasive candida infection, candida albicans infection of skin and the mucous membrane. There is absent in vitro. So chronic mucocutaneous candidiasis, always think of the candida. Absent in vitro T cell proliferation in response to candida antigen and absent cutaneous reaction to candida antigen. I for interleukin 12 receptor deficiency, decreased T helper 1 response, autosomal recessive. Interleukin 12 receptor deficiency, there may be disseminated mycobacterial and fungal infection. Disseminated mycobacterial and fungal infection may present after administration of the BCG vaccine and may present after administration of the BCG vaccine. Disseminated mycobacterial and fungal infection. Interleukin 12 receptor deficiency decrease in interferon gamma, a most common cause of Mendelian susceptibility to mycobacterial diseases. Mendelian susceptibility to mycobacterial disease, interleukin 12 receptor deficiency. And thymic aplasia, there is DJOR syndrome, there is velocardiofacial syndrome, DJOR 22q11 microdeletion failure to thrive, third and fourth pharyngeal pouch absenthymas and parathyroids. So absenthymic shadow, like skid. If skid has absenthymic shadow on chest X-ray. And thymic aplasia catch 22 cardiac defect on truncal abnormality of tetraloser phallat truncal arteriosus. There may be abnormal phases, thymic hypoplasia, T cell receptor deficiency, recurrent bacterial, viral, and fungal infection. There may be cleft palate hypocalcemia secondary to parathyroid aplasia and tetany. And DJOR syndrome is catch 22 velocardiofacial is facial palate or facial cardiac defect, palate facial and cardiac defect. Okay, see the brutons again. There is BTK gene mutation, impaired B cell maturation, and immunoglobulin production, recurrent sinopulmonary infection, and GI infection at age 3 to 6 months. So brutons for babies, chronic enteroviral infections, smaller absent lymph node, tonsil, adenoids, decreased immunoglobulin, and decrease immunoglobulin and antibody response to vaccine, decrease immunoglobulin and antibody response to vaccine. Flow cytometry is decreased CD19 on B cell, decrease CD19 on B cell and normal T cell, immunoglobulin replacement therapy and prophylactic antibodies. Look at the CVID, CVID abnormal differentiation. C goes with the D, differentiation of the B cell into plasma cell. So decrease immunoglobulin production. There is recurrent respiratory tract infection, sinusitis, otitis media, recurrent GI infection, salmonella, campylobacter, giardia. There may be chronic causes, autoimmune RA, thyroid disorder, pulmonary bronchitis, fibrosis, and GI. Chronic diarrhea, IBD-like condition, decrease immunoglobulin response, decrease IgG and IgM, and no response to vaccination. In CVID, there is no response to vaccination. Diagnosis is no response to vaccination, and in brutons there is decreased antibody response to vaccination. Brutons is decreased antibody response to vaccination, and cvid no response to vaccination. There is no response to vaccination in cvid. Management is immunoglobulin replacement therapy. Management is immunoglobulin response therapy. So CVID should suspect in adults, childhood. Uh, so Bruton for babies, CVID for adulthood and adolescent and childhood. Okay. It occurs in adults, 20 to 40, adolescent around puberty. What test is used to determine CVID? Quantitative measurement of serum immunoglobulin. Quantitative measurement of serum immunoglobulin, which deficiency is characterized by no B cell maturation. Uh, no B cell maturation is X-linked Bruton agammaglobulinemia, and in CVID there is poor B cell differentiation. So in CVID, C for D differentiation, in Bruton's B cell maturation, absent B cell maturation, absent B cell maturation. Okay. Now look at this box, selective IgA deficiency. Most common primary immune deficiency, usually asymptomatic recurrent sinopulmonary and GI infection, autoimmune disease, celiac, atopy, asthma, anaphylaxis during transfusion, low or absent IgA, normal IgM, and B cell supportive care, medical alert bracelet for transfusion reaction for severe deficiency, transfusion reaction for severe deficiency. And now the most important T cell disorder, autosomal dominant hyper IgE and Job syndrome, deficiency of T helper 17 due to STAT3 mutation. Job JOB3 STAT3 mutation impair recruitment of neutrophil to the site of the infection. Impaired recruitment of the neutrophil to the site of the infection. Impaired neutrophil recruitment to the site of the infection. There is cold, non-inflamed staphylococcal abscess, retained baby teeth, coarse faces, dermatological problem, eczema, increase eczema found in Mr. Text, viscodal allergies, also in hyper IgE and Job syndrome, increased IgE, bone fracture from minor tumor. Let's learn an ABCDE to get a job stat. Increase IgE and increase eosinophil, increase IgE and increase eosinophil. Now look here, hyper IgE, autosomal dominant defective JAK stat signaling, defective JAK stat signaling, impaired T helper 70, decreased neutrophil proliferation and chemotaxis. There is eczema. There is a cold abscess, hyper IgE, cold abscess, eczema, sinopulmonary infection, dysmorphic faces, broad nose, prominent forehead, retain primary teeth, dysmorphic faces, impaired T helper 17. So on lab, increased IgE eosinophilia, low normal leukocyte count with decreased T helper 17, supportive care, antibiotic prophylaxis and treatment, antibiotic prophylaxis and treatment. Finally, at last, if we see these box in selective IgA deficiency, remember the B game, IgA deficiency. So everything is normal, B cell count, G a is low, M is normal, E is normal. B game, Job syndrome, hyper IgE syndrome. IgE is higher and everything is normal. CD40 ligand, hyper IgM syndrome. Mm, B cell count is normal and hyper IgM is higher and GAA is low. Age is low. Age is low. In CVID, in CVID, and in Bruton's acamoglobulinemia, there is defective B cell maturation, so no B game. Everything is low. In CVID, there is a problem in the differentiation, so there is presence of B cell count, and the game is low. So that is all about B and T cell deficiency. Hope you enjoy.